All right. So I couldn't be happier about a grand round speaker today than with Jay Wellons. Jay is a rare friend and an outstanding person on every level. Originally from Tennessee, he was an intern when I was a chief resident at Duke. I helped him with his first EVD. Now he helps me when I need surgical advice. We did the same fellowship with Jerry Oakes at UAB a few years apart, but he was good enough that they asked him to stay on as faculty. He stayed for 10 years, during which time he also completed a master's in public health. So Jay moved to Vanderbilt, where he did an incredible job in building a clinical research mecca. His master's degree helped ground him in medical statistics to become a very productive member of the Hydrocephalus Clinical Research Network. But at Monroe Children's at Vanderbilt, he built a clinical research center called SOX, in which he galvanized not just the pediatric neurosurgeons, but all the pediatric surgical specialists to organize their research and publish widely. I'm hoping that at one point he would visit us and teach us from his experience. Jay has over 250 publications, and he's an expert on Chiari malformations and brachial plexus surgery. However, the reason he's here today is that he's arguably the foremost expert on fetal myelomeningocele repair nationally. And we are, as many of you know, starting a fetal repair center here with the help of Ina Lobek and Raheel Ahmed. When Jay joined Vanderbilt, he followed in the footsteps of Noel Tulipan, who introduced us to fetal repairs. But Jay took it to another level after the MOM study and taught us about long-term results, technical nuances, and how to build such centers. Finally, if it's not enough, Jay has published 2 articles on patient experiences in the New York Times. And in June, he has a book coming out in which he describes his experiences as a pediatric neurosurgeon and physician. The book is called All That Moves Us and is published by Random House. With all of this, Jay remains a wonderful family man, so I guess some people can do it all. I couldn't be prouder to have anyone here, and I'm sure everyone will figure out why after his talk. But as we all know, unfortunately, no one's perfect. One thing that Jay lacks terribly is that he's never really been able to have a sense of humor. He's just not funny. But it's a minor thing you can hide in the operating room. So Jay, thank you so much for coming today.
Well, it's a great honor to be here, and thank you for that introduction. Vinny, I appreciate it a great deal. We've been friends for a long time. And this is a topic that I'm fortunate enough to learn a good bit about when I came to Vanderbilt, just like Vinny said. So I wanted to just take some time to talk about kind of what I call the state of fetal spina bifida surgery after Wellons. Really, from a clinical research standpoint, it's also the subtext title, which is what is the role of a surgical study center once the study is complete? And I think that's an important thing to take note of as we kind of go through this talk and just kind of think about what that means. If every other center shut down for basically 10 years so that a study should be done, what happens when that study is finished? Does that mean those 3 centers should remain the only 3 centers that do it? Or does that mean that the centers should be part of educating and teaching and advancing the field? And obviously, I would argue. Disclosures, I have no industry-related disclosures through the HCRN and Mark Reeves Network. There's funding and there's other various disclosures. To talk, just scroll a little bit out the folks that I work with here at Vanderbilt. Rob Naftel is a terrific colleague who does our epilepsy and spasticity surgery, and I've known Rob since he was a second-year medical student. Chris Bonfield, a terrific partner as well, as our craniofacial spine. Michael DeWine joined us 2 years ago to help grow the brain tumor and vascular programs. Haley Vance is the person that everybody likes more than the rest of us anyway, because she does such a great job helping take care of our patients. And then Charles Markham in our clinic, and to have a terrific fellow this year, Mike Pools, to rotate with us. So I think just circa 2022, I'm pleased with where our group is and looking forward, to the future too. I did want to mention just briefly the long shadow cast, being somebody who has known many as time. Just like you said, showed me how to put first ventriculostomy, and that was in 1994. Visited Duke as a sub-I, and actually remember doing a craniotomy with Benny where he taught me how to float the gel foam up to the surface, and every single solitary time over the last 30 years or 28 years that I irrigate gel foam out of a cavity for some reason, Benny's voice comes to mind to just let it float up. And then of course followed him to UAB, and there was a shadow cast with all the amazing academic work that he had done. And then this wonderful experience when I visited his early academic practice. Jerry Oakes, our mentor, said, "Why don't you go visit Benny up at Wisconsin? He seems to love it there." So for the last few days of my fellowship, they sent me up to visit with Benny and just see how he had set up his practice and his research and the colleagues that he worked with. I remember meeting Dempsey, who said, "Any friend of Benny is a friend of mine," which I thought was very kind to say. And then with Benny, and we would walk into a patient's room, and he would say, "Mrs. Johnson, this is a very good friend, Jay Wellons, who is a pediatric neurosurgeon in Nashville. And I have discussed your child's case with, and he agrees with everything that I'm doing." And he did that over and over again in every room that we went into. And I realized that I think he had a purpose for having me there. And then, of course, our families, great friends to the P section and the ASPN, and our mutual admiration. And Tim George, who was a mentor of both of us. But I do want to say that Benny's a bit timeless. This is the oldest picture I could find of him. And if you look, there's not much change. And over the years of, there's Jamie as a young child, us younger, obviously wearing bandanas, and there's just not a significant amount of change. And I said to myself, that's wild, that there's just not that much change. And then I said, well, it's not really wild. It's Oscar Wilde. And in the portrait, the picture of Dorian Gray, which is a classic story. And I just think probably if one of the residents went upstairs in Benny's house, there's going to be a closet with a picture of a very old, Lebanese American man. And so, but don't stab it like he did in Dorian Gray, because I like Benny as he is. He's doing pretty well. So I just part of the comments about the long shadow is just to say that I've had a wonderful opportunity to be friends with Benny for a long time, and he's influenced me in many ways, both at Duke and at UAB and beyond life. So I'm very grateful for that friendship. I'm also, grateful to, be visiting a program that, has folks that I've had the opportunity to run across and know through organized neurosurgery. Dr. Dempsey, of course, and then Wendell, who was a terrific colleague who was here. Dan Resnick, back when I was program director and more involved with the CNS, and then Benny introduced me to Josh Meadow. But switching to Vanderbilt, you really can't talk about fetal surgery at Vanderbilt without talking about Noel. And Noel retired in 2015, and he was a very quiet and unassuming man. And the only way that I was able to get Noel to agree to having a retirement party was if he also wrote a book, 2 books of fiction, ironically. And so I convinced him that we would have a book signing party, and we turned that into a retirement party. Here you can see pictures of him, both in the early aspect of his career in the heyday of fetal surgery here, and then also with various colleagues. I think it's important to understand, how a fetal center develops. And Junior League, it's called the Junior League Fetal Center at Vanderbilt, really began with the fetal surgery closure of spina bifida. And the origin, as I said, was Dr. Tulipan and Joe Bruner, who is a standing maternal fetal medicine physician. And really, they just, the 2 of them began to, at the same time, the CHOP began to do fetal surgery in children with spina bifida. And if you look at Noel's CV, there's a long history of case reports to case series to case controlled studies to ultimately the mom's trial is so impactful. We'll talk about that in a bit. But in the early days, it was really our neonatology colleagues, and I put Bill Walsh here because I really think Bill Walsh needs to be extolled as an important member of this early team, because he's the one that said, these babies are being born pretty early, and there are some issues here. And we just can't run fast and free with fetal surgery and not recognize that there are some issues that are coming. And so that was a tremendous, in order for the entire field of fetal surgery to take a kind of the next leap. Now 20 years later, it used to meet half day a week. Now it meets 5 days a week. It sees 2,000 patients a year. Wonderful family has donated money to have a new maternal fetal center and clinic for the patients. And so it's really something to see, and something that I know that Noah would be proud of and was proud of at the end of his career. Now it's not just fetal surgery for spina bifida. It's all the things that you see here, from cystic hygromas in the lung to sacral coccygeal teratomas to omphalocele to diaphragmatic hernias. But it's also really important to recognize, as pediatric neurosurgeons and as neurosurgeons, that fetal surgery for spina bifida is really one of the only two indications for fetal surgery, the other being twin-twin transfusion. And so, to date, the data for fetal surgery in other areas is way less robust than areas that I just mentioned. And also, I would add, fetal surgery for spina bifida is also a non-immediate lethal defect. It's different from twin-twin transfusion. So the decision-making process to move on with fetal surgery is not a small one. It's the implication. So, here's an MRI scan for my spine colleagues. Try to, move your eyes away from the lumbosacral spine, to the uterus. You can see obviously the brain, the ventricles. You can see the bladder, and you get a sense for where the head is in relationship to the body. And then if you look up here, you can just see this little defect right here, which is the open neural tube defect. And if you kind of line that up with a picture of a baby, you kind of get a sense of what that lesion looks like in comparison to what it looks like on MRI. Now, we all know as neurosurgeons that this lesion is quite different from this lesion, and not just in how it's closed in terms of primary versus a complex repair, but also in the function of the bladder and legs and the scoliosis and all the issues that follow. So it's really, again, a decision-making process in order to move forward fetal surgery. And I think we have to rely on the literature to date, and then also help add to the literature as we move forward. So kind of into this breach came the mom study in that environment of, hey, we need to make sure that we're doing the right thing here. It was a study that took place over 10 years. It was randomized, which is a big deal for a surgical trial at the time. And still, we are in the HCRN and Park Reeves, we do randomized controlled trials for patients. And there's a lot of challenges in surgical randomized controlled trials in terms of getting people enrolled, at least in the field of neurosurgery. And so, what had to happen across the field was that every center had to agree to stop. And then the only way to get fetal surgery was through the trial. And then you were randomized to either intrauterine or postnatal surgery. It's also interesting to note that the outcome was hydrocephalus. It was adjudicated hydrocephalus, but also placement in the shunt. And then also there were various composite outcomes that had to do with neurologic developmental outcomes. That includes ambulation, and that includes also mental aspect of the BSID, the Bailey's developmental. And then, of course, at the end of the study, lo and behold, it was published in the New England Journal of Medicine. And I can remember a colleague emailing me the night before that said, there's a press release that's about to come out from the NIH, and it's going to go over the results of this trial that's going to come out in the New England Journal of Medicine. And they had to halt the study. When I heard that, I was like, aha, they had to halt the study because there was a problem. Well, actually, they halted the study because it was so positive that even if every child after that point would have not gotten the benefit of fetal surgery, it still would have been a statistically positive study. So to get a sense from the power of statistical modeling and those really critical kind of check-in points that you afford power to, that allows you to look in and see, and that's exactly what happened in the study. So, I think this is probably the beginning of the picture that everybody wants to see, which is, what does the uterus look like? And this is Kelly Bennett, who's the MFM leader for the team. And right now, the ultrasonographer in real time is looking for kind of lacunes or large areas of venous blood within the uterus. And Kelly is beginning to dot out where the incision will be on the uterus. But I do think it's also important to notice that there's a lot of people around the table. And we were honored to be asked by Dr. Rutka and the team at J&S for the 75th anniversary to write a review on fetal surgery for spina bifida, and my partner Michael tremendous help in that. And you can see from this diagram, that there's 5 people around the table, which is with an ultrasonographer, and I often call it neurosurgical twister, because sometimes you're really elbow to elbow with the other people while you're trying to do this repair. The other point that's important to make is that this is an operation where there's a lot of what they call here dark ring badges, which is people that are that are senior up in the surgical field. But this person standing here is a neurosurgical trainee, and that's very important to me that our fellows and our senior and our junior residents, have the opportunity to be a part of that. And I have, residents who have been here that have done enough of these to feel, competent and capable moving forward in the future. And I do think that's important because, spina bifida and the closure and the repair and all the issues that are to come that we'll talk about in a bit, those are really things that are neurosurgical, and the implications of how the closure is done, tethering, CSF diversion, those are things that we really have to be on top of as these children mature. And I think those of us in the field of pediatric neurosurgery understand that. So again, here's the dotting of the opening on the uterus. And then here's a little bit of a distant shot that shows the uterus exposed. And you can see these kind of really heavy chromic stitches that are put in. And we'll talk about that later as a way to help reduce preterm birth. And then a stapler is used to open down the one side of the uterus, depending on where the cocoons are. And then you can see the neural tube defect there. This is a close-up of that same picture. And, really it's a little bit like the scene in Hoosiers, when they go into the final act, when they go to the big civic center and they have the guys walk in and they measure the goal to the ground. They measure this side to side. They realize it's a basketball, just like, basketball, just like ones that we played on before. I think it's important to recognize that, yes, it's smaller, but it is a myelomeningocele. We can recognize the neural placa. We can recognize the dysplastic arachnoid skin. And we can, with a look, really understand if that's going to be a primary closure or if that's going to require a more complex closure. And one of the things you have to be facile with is that you really don't know. We've tried to look at measurements, predictors, ultrasounds, MRIs, and at the end of the day, you really have to make that decision once you look at the lesion and see the tensile strength of the skin to understand if it's going to be a primary closure or not. And that's why it's nice to have, we have a plastic surgeon that's part of our team, that if it looks like that we need to do bipedical flaps, then the plastic surgeon will rotate in, and then he and I together will make incisions on the flanks and then sew in. And I'll talk about that as we get on. But basically, this is the repair. So, it's beginning to separate the neural placa away from the dysplastic skin. And then, kind of rolling it up and make sure it's separate all the way around. And then I'll oftentimes, this is something that Noel taught me, I'll take the scissors and just feel the dura, see if I think the dura is thick enough to be able to close or not. And often, if it's a fetus that's less than 24 weeks, then oftentimes it's not. If it's 24 or 25 weeks, then sometimes it's possible. Sometimes people will dissect down into the muscle and roll that over as a separate flap. That's not something that we do at Vanderbilt because that's not something that we feel is necessary, and I think our outcomes bear that out. There's a lot of lost muscle tissue. There's a lot of blood loss that can occur with that. And so oftentimes what we'll do is dissect on the skin out to the sides and put a piece of DuraPair on it, and then bring the skin together. And, you basically kind of see the steps that are there. And then I just kind of have humorously named it the tulipan method, which is, placo dissection, check to see if the dura is able to be closed primarily or just an onlay of DuraPair. You dissect the skin on both sides all the way out to the flanks. It's kind of a quick decision for flaps. Sometimes it's if I think it's at the border, I'll try to put a stitch in. And if it's not going to hold, that tissue is really friable. It's almost like wet tissue paper sometimes. If I don't think it's going to hold, then you have to have a plan for how to close it. And again, post moms, the environment is some people will sew a large patch onto the midline. We choose to put the good skin over the midline and then let the patches be on the side. And again, I'll discuss the results of that later. But once we get the midline closed, then if we ended up having to do some of those flank incisions, then we'll just quickly patch those with Flex HD or some type of collagen patch. That the neurosurgical part of it, as you can see, it takes around 20 minutes, up to 40 if you've got to do bilateral patches. And that's an example of that patient's skin once the baby's born. It is remarkable, kind of once you quote, put the bread back in the oven to bake a little longer. It is kind of amazing how the fetal skin has a propensity to heal, and the tissue does really have a propensity to heal if you get good tissue to good tissue. Okay. So what are the goals? I kind of briefly talked about what the goals of something like this are. It's to further evolve the understanding of the mom's data, refine the surgical technique, and train other centers. And so if we talk about the mom study, you can see we talked about the primary outcome being, adjudicated treatment of hydrocephalus or placement of the shunt, and then also the actual placement of the shunt. And then the secondary outcomes, which we discussed. And here are the results. The primary outcome of adjudicated whether or not a shunt needed to be placed or not. There was a 5-person group that looked at these things that were blinded. 68% with the prenatal surgery went on to a shunt, and 98% postnatal shunt. And then if you that were adjudicated to do so. And then if you look who actually went to get a shunt, you can see the difference is even greater. So again, the adjudicated outcome that this person needed a shunt or not when blinded was 68 to 98%. Actual shunt placement was 40% to 82%. So there is a little behavioral difference here. We dive into that later. Also, the degree of hindbrain herniation is less. The degree of brainstem kinking is less. The other kind of primary outcome, yet it's different than CSF diversion, is that of this kind of psychomotor outcomes. And it was actually a composite outcome between the Bailey's Mental Development Index and difference between motor function. And I think it's really important to get this because at the end of the day, there was no difference in the Bailey Mental Developmental Index. It didn't improve their cognitive function. But what it did improve was basically the difference between what was the expected level versus the actual level. So there was a higher group that went on to have more than 2 levels of improved function. So again, it is important to note, this is not 90% of the kids move on to walk, whereas 20% of them would not. This is it's an improvement. It's an over doubling, but it is something that's important for folks to know when you're meeting with the families about what the real outcomes are. Then some of the negatives, like we're talking about by our NICU colleagues, there's a much higher proportion of chorioamniotic membrane separation, oligohydramnios, spontaneous membrane rupture, spontaneous labor, and then gestational age was lower in the intrauterine group, and then you can see there were more that were born earlier than 30 weeks. So that's an issue, and I think that's a target that was pointed out when the paper came out in 2011 for how what we target to impact in these last 10 years or so. So end of the day, shunt placement was better, motor level was improved, spontaneous labor was worse, and gestational age of birth. And so just in case Vinny's tuning out, just the 3 shunted less, motor function better, earlier delivery. Those are the things to take. So into this came, I came to Vanderbilt. Noel let me settle for about a month before he said, let's put that degree you got into good use, and we wrote a proposal on looking at, kind of the predictors of CSF treatment. And we submitted that to the mom's investigators, and then ultimately we got the data, wrote the paper, it was approved. I just really want to focus on this prenatal predictors of CSF shunt placement and postnatal predictors. And that'll be a little bit more obvious when I talk about it. But a priori in the mom's study, these were variables that were set aside to look at. Gestational age, dichotomized. Lesion level, dichotomized. Ventricular size, trichotomized. Hindbrain herniation, you can see the areas that were separated there. Then, basic steps were used to look at it. And if you look here, if you dichotomize gestational age, when the moms underwent surgery, the fetus was less than 20 weeks versus greater than 24 weeks, there was some implication that the age of that mattered, and the younger might be a little better. But what really mattered was ventricle size. And what I mean by that is that if the ventricles were less than 10 millimeters at the time of screening, so when you meet with these families beforehand, and you're sitting at the table and you're trying to tell them if fetal surgery is going to benefit them or not, if the ventricles were less than 10 millimeters on standard measurements, that made a tremendous difference in those that went on to get CSF diversion, prenatal to postnatal. You can see the percentages there. But as you get over 15 millimeters, the difference really goes down substantially. There's still a difference, but it goes down substantially. And then if you do, the appropriate, multivariable modeling, you can really see that it's ventricle size that stands out more than gestational age. So we can say that when we're screening pregnant women for intrauterine meningeal closure, the ventricles are large. There's not really a clear benefit in regards to the primary outcome of shunt placement, but the earlier the better, maybe. So what about postnatal predictors? So what is it about the difference between the adjudicated group that was standardized based on these criteria for shunt placement and then the actual placement of the shunt? Because from a sociologic standpoint, I would argue that the mom study actually impacted surgeons on what we do in terms of when it's time to place a shunt and how we determine when it's time to place a shunt. But at the time that the mom study was set up, these are their criteria. And I'll focus on the top criteria. I'm happy to talk about the lower one at a later date, but really, it needed to have at least two of the following: an increase in OFC adjusted, bulging fontanelle split sutures or sunsetting eyes, increasing hydrocephalus on consecutive imaging, or a large head to begin with. Those are the basic things. You needed two of those things. Okay, so just kind of focus in on this 1B: bulging fontanelle split sutures or sunsetting eyes. So if you look at the primary outcome, which was adjudicated shunt placement, difference was, as we said, 68% went on to get a shunt in the intrauterine group, and 98% went on to get a shunt in the postnatal. The actual shunt place was different, 40% to 82%. That's a pretty substantial difference. So we said, what if we mandated 1B? What if we mandated, this was a little bit based on some of the data we had in the HCRN about how surgeons make decisions for preemie IVH in terms of, when to temporize, when to shunt, when to make those decisions. So we hypothesized that it was 1B, which was the biggest impactor, and it turns out it was. We looked at each aspect of it. And then if you mandated a split of the sutures or a bulge of the fontanelle or sunsetting eyes, that difference dropped, substantially, right? And so that was really the key difference. Like, when infants didn't have those symptoms of hydrocephalus, the incidence of shunt placement was substantially reduced. And so kind of the takeaway from that is that they really were prioritized by surgeons, over OFC and over vent size. And I think that's another important takeaway. Then, other papers have come out since then, and I want to be mindful of the time, but basically it was important to decouple ventricle size from function. And that's what this paper did in the American Journal of Obstetrics and Gynecology. At the end of the day, you can see, looking at walking independently, looking at the difference between functional and anatomic levels, those things are decoupled. So the benefit was sustained with surgery. So if somebody had large ventricles and they might not benefit from placement, from prenatal surgery for the large ventricle standpoint, from a functional standpoint, it did really imply that was still an important thing to do. And so I think, that paper showed us that the outcomes of moms were sustained at 30 months for the entire cohort, which was pretty clear, and the vent size was decoupled from motor outcome. say maybe there, but I think over time, I've realized that it's a yes. And I've realized it's a yes because of papers that have come out since then. This came out in pediatrics, prenatal repair, and school-age functional outcomes. And these benefits are sustained. So less kids go on to get a shunt. If they got a shunt, less of them get revised. And also, by the way, their ability to walk independently is sustained. And this is the most recent paper that's come out in JAMA Peds that basically said function is sustained at school age. And so I show this just to say, if we could travel back in time to 2011, there was a lot of skeptics of the results of the MOM study. And if we could show this paper that, this is kind of the holy grail paper to me that says it does sustain. This isn't like, an aspirin, a beta blocker after cardiac surgery where it separates and then over time stops separating. Like that, this difference is sustained, and that's a big deal. And I think that helps justify, the doing of fetal surgery and the continued institutions beginning it to offer it to their patients because, again, it's sustained, and that's a big deal. So what about refine the surgical techniques? There's a lot of different aspects here. I think you can look at hydrocephalus and say there's no doubt that the culture of CSF diversion has changed since MOMS. There's no doubt. I mean, you can look at just in the HCRN and the papers that have been published about ETV, CPC, and ventricle size, and the difference between shunting and ETV and CPC, and that's just substantial. And I actually believe that the MOMS study had an impact on how we view ventricle size. And we can have a long discussion about Ben Orf's kind of career, dedicated career, moving to Uganda, spending a substantial amount of his time moving his family there, doing ETV, CPC, and these children, and then what we tried to do in the HCRN is kind of redo that work in a North American population to be able to show that there does appear to be some durability and sustainability of it. So it's important to note that what we look at in terms of how we put a shunt has changed. Whereas the shunt criteria back in MOMS might say if the ventricles are large already. But now it's clearly that 1B. 1B kind of reigns. And if you look across different areas of hydrocephalus, this concept of treating a child with a sunken fontanelle and sutures that aren't split just because they have large ventricles, that might have been the way it was done 20 years ago. And I can remember me personally closing a Milo and looking at the image and posting them for 3 days later to put a shunt in because that was just the heuristics of the time. And now I look how different that is and how rare it is for us to even do CSF diversion in the time that the child is in the hospital after the myelomeningocele closure, and how oftentimes that decision is made over serial measurements over time in our spina bifida. And, we had a good meeting with Jeff Lout, almost 10 years ago where we just said, there's a lot of things that are acting on this. Folate, MOMS trial, what I call the Robin-Bowman criteria, which was the less aggressive shunting of patients, make them show us the 1B criteria, and then the aspect of ETV, CPC, and all of that just kind of overall reduces the incidence of shunt placement. We know from the HCRN, the studies that are done, that the way that you reduce the incidence of shunt failure is reduce the need to operate on the shunt. And the way that you reduce the need to operate on the shunt is really critically think about, does the patient need CSF diversion or not, and are there other options for them to do so? So preterm birth, I'll touch on this quickly. I mentioned those heavy chromic sutures that Kelly's team puts in the wall of the uterus. This was a paper that we published in JNS Peds earlier on that just basically shows that if you really spend a lot of attention to that detail and really sew the uterine lining up to the wall when you do it and spend that time to do it, and we compared that postnatal group to the fetal moms group, the incidence of PROM was substantially better. Periamniotic separation was substantially better in comparison. Term birth was higher, which was all of it basically was improved compared to mom's fetal cohort. So I always think, it's not, as neurosurgeons, we think about the milo closure, but one thing you learn is that it's a big team in there. Everybody has their role, and all those roles are important. And just because you walk in for 17 minutes and kick the field goal at the end doesn't mean that the opening and the closing of the uterus and the anesthesia and the exposure and all those things are equally as important to the work they do, because they are. They're very important. This kind of thing I think matters. This got published in the Neurosurgery journal, but it was about uterine manipulation. Right? Just a big point to make. What about tethering? So what about this issue of if you've got a wide lesion? Do you sew a patch over the middle, or do you do bipedical flaps and put the good skin over the middle and sew the patches in on the side? And this was an early paper that was done back in 2000, because this was the beginning of and the team here had thought that this would be the most reasonable way to do it. So, what we did is we just looked at the results from 2011 to 2021 and found 44 primary closures, 22 with bipedical fasciocutaneous flaps that we had adequate follow-up on. And you can see there was a difference in operative time. I mean, obviously, if it's wider, it's more complex. Think about the postnatal myeloclosures. It just takes longer to do those. But gestational age was the same. And the dehiscence rate actually went down. And that's because instead of stretching these flaps, to a point where the skin's tearing, we actually did some dedicated effort to try to reduce the incidence of dehiscence and really be able to get these flaps together. And that made a substantial difference. And then if you look at the results, there's really no difference in terms of CSF diversion and ambulatory function in these simple versus complex closures. So, what can we say? Bipedical flap closure does not increase the risk of preterm birth. Wider lesions are not a contraindication. And really, what our future direction is to fully evaluate these primary and secondary outcomes. So a couple more points to make. I think, let's be real, really don't have a clue what's best here in terms of tethering. We have recently looked at the fact that that we do this closure in a way where we, separate the placode, we then dissect underneath the skin, we then oftentimes we'll place a piece of Duragen on it and then close the skin. And conceptually what we wanted to do was just look at those patients compared to postnatal patients. And we measured the distance from the actual placode and dura itself to the skin. And we actually looked to see if there's any difference in tethering rates. Because to me, if you can make this procedure as straightforward as you can make it, right? If you can say, this is what you need to do, these are the most basic steps, whether it's a Tulipan method or whatever, and these are the basic steps you have to do if it's a complex, then it becomes something that's reproducible. And then it's not just reproducible in North America, but one day it's reproducible around the world in areas that we can't imagine being. I think that's really important when you're doing this type of work. If you make it overly complex, then people aren't going to be able to, people can do it, but I think it's going to be able to be done more often if there's more people, if it's as simple as possible. And then subsequent delivery, and then I can talk a little bit if we want to about fetoscopic surgery. Benny, am I doing okay for time? Are we good?
I think people will start leaving in about 5 minutes, Jay, to go to surgery.
Okay, great. And I'm really basically done. I mean, I think at the end of the day, there is a role for fetoscopic surgery. There's a series of papers that were done by our colleagues at Texas Children's that basically kind of is a nice stepwise progression of fetoscopic surgery. I do think that there's still, as a primary goal, the goal is to get back to vaginal delivery. I think at the end of the day, you can see that up to 50% of the patients that were done here were able to go back to vaginal delivery. And I do think that's important. And I do think it says a lot about the field that we've gone from CSF diversion, focusing on that, to functional outcomes, to to early birth, to tethering, to all the issues. And now we're at the point about whether or not a woman can go back to having a vaginal delivery. I think that we're not quite at the point where we can say that that the other aspects are equal as well. What's the issue with tethering? What's the issue with CSF diversion? What's the issue with function? And are those things sustained as well? But I mean, again, this is what we wanted to do when these groups came to be taught. It's basically, come and see what this, that how we make the decisions and what the decisions like in the OR, and how it's important to have a team that is, all simpatico with one another, because there are some quick decisions that have to be made. But also, like, what are the next steps in terms of how we make that feel better? And if we make it like an open source code where people go and can design ways to make it better, then I think the overall field improves. So we tend to be a place that says, it needs to be done better than the way it was done in the mom study. And I think that's really important. And just as I mentioned before, and this is winding up, just to have the opportunity to train other centers. And I just got some Circle Texas Children's early on, and their time came, and we had an amazing opportunity to go to Australia to help fold in with the team there to do the first procedure in Australia and that part of the world. And we were able to go up and help the team at Sick Kids get going. They've just been going like gangbusters since then. And what happens, and it's just kind of the areas of influence. I think that whenever I think about Noel's career and kind of what he started, went from being the person that had done the most of these, like I said, in the known galaxy, to now looking at the influence of the techniques that the people that did this surgery initially have done. It's pretty profound. But let's be honest, what happens at our center? In our center, when you teach people to do it, then they don't refer you those patients. And so that means that instead of getting 12 patients from Canada, now Sick Kids does those patients. Instead of getting the ones from Kansas, from Kansas City when Paul Grab came, he's doing those. That team up there is doing those. So it does fair to say, like, how many is the minimal amount? What's a reasonable amount to be done? And I think those are great questions. And we're fortunate to have a good team and have a nice referral pattern from the Southeast. And I think the bigger questions of how many need to be done by each center, those are questions that I don't think I can personally answer. I think those are questions for the larger kind of corpus pediatric neurosurgery. And this is just the last slide, just kind of showing the team that was in Australia and the really kind of neat, kind of all eyes of medical Australia at the time. The opportunity to blog about it. Just a really neat time. And I think about the influence of what, like I said, what Nolan had. So I know I kind of ran through this quickly, and I'm sorry about the microphone issues at the beginning. I think maybe Benny just let me talk so I wouldn't rag on him. Then when I was done, then he let me go scientific. But thank you for letting me to give a talk up here. Really, when I told Reed Thompson, our chairman, that, oh yeah, it's really neat, I'm going to do a web talk with the Madison team, he was just like, oh, that's a great group. That's a great group. So cheers from the team here. Grateful for the collegiality that we have between our two. So with that,
Jay, thank you.
Yes, sir.
It was really phenomenal how every time you said something nice about Benny, your microphone went dead, and everything, all the science was perfect, and we heard all that clearly. This was great. This was great. It's really, it's inspiring that you take a difficult problem, you look at it scientifically, and you inspire other people to improve upon that. And it's a start. It's not an end. It's a start, is what it is, and that's important. We can't thank you enough.
Thank you. I appreciate your time.
Jay, thanks. That was great. I won't take a lot of your time. I'm sure Raheel probably has some questions. A lot of techniques are changing now. Obviously, they have to change. You can't be doing it like 2011. The problem is you can't run a randomized clinical trial every time a technique change, right? Every time you do a new dural graft, every time. So how are we to believe whether fetoscopy is more superior in the next 10 years or whatever other technique comes out, robotics, tissue engineering? How do you, what's the plan?
Well, I think it's a great question, Benny. And I think it's one that begs a lot of thought. There is NAFNET, which is the North American Fetal Treatment Organization, and that's a group of fetal surgeons that looks at these outcomes critically. But and there is a database, and that database is not heavy in neurosurgery aspects. I think you may have set me up for this, but I've spent some time petitioning for more data from a neurosurgical standpoint, because I agree we can't run off and do an RCT. We're having challenges, to be honest, randomizing between infants for a shunt versus ETV-CPC, because most folks come now with the paper in hand, or we heard about ETV-CPC and we want this, and so there are challenges to doing RCTs now, particularly in kind of the media-driven and information access, you know, ability that we have now in society. And so I think it's going to have to be a registry study, just a well-done registry study. Almost the way I look at it, Benny, is almost like a phase 4 drug trial, right? So,
Right.
You do your phase 3 trial with your RCT, and then you look to see if Vioxx causes any problems over the next 2 years. And lo and behold, there's a higher incidence of X, Y, or Z. And so, the drug is labeled or pulled off the market or whatever. So I really do feel like that the way that we're going to do this is by these registry studies. And frankly, doing some of those papers that I mentioned is I think the first step in saying, look, guys, we have valid different ways that we're doing this. And is there a better way to do it or not? And if there's not, that's fine. But if there is, then I think we should all begin to do it. And the fetoscopy thing is a little bit challenging. There have been some centers that have incorporated and then they pulled back. And that's just because of some of the challenges. And look, let's be frank. And I know that I believe our pediatric and fetal surgery colleagues are on this, and our MFM colleagues too. But we don't train in laparoscopy, right? And so are we going to say that therefore, as neurosurgeons, the closure of the placode and the back, we're going to abdicate that to somebody else entirely, which to me I think is the cornerstone of what pediatric neurosurgery is about: the care of spinal bifida patients, who we see in clinic, who we manage their CSF diversion, who we manage their tethering. So I do think it's an issue that we're going to have to take on. And the last thing I'll say about it is that, and I've begun to talk about this openly, and it just has to do with time and the ability to do things. But I do think robotic surgery is way more facile in this fetal environment than what I call straight arm laparoscopy. And I've had the opportunity to work with some really terrific robotic surgeons here. And it's way more like what we do on a microscope than we think. So I'll just leave you with that.
This was great, Jay. Thank you. Do you have a feeling if the improvement in the functional status is independent of the hydrocephalus or shunting outcome? The reason I ask is sometimes fetal ventriculomegaly is used to counsel against the fetal closure, which makes sense from the shunt standpoint, but shouldn't take away the benefit of the neurological improvement postnatally, right?
Yeah, you're 100% right. And I'd sped up a little bit because I had a lot I wanted to get out. But there was one important paper that kind of decoupled this issue of ventricular size versus functional improvement. That was that second paper that came out in the American Journal of Obstetrics and Gynecology. And it basically showed that 30-month outcomes were sustained and decoupled from ventricle size. But look, if I'm sitting in the room down here with a couple and they have a child that has a low thoracic myelin and the ventricles are 20 millimeters, I'm gonna counsel that family that there's not a clear benefit because the ventricles are large. We're not going to not have CSF diversion is equally as likely, and the addition of 2 levels is not going to make a substantial difference. And other than the radiographic improvement of QRE2, there's not been any publication that's shown a decrease in the symptoms of the QRE2, other than a recent paper by Paul Grab that implies it. But the point being is that, again, to me, it's a big commitment. There's risk to the parent, there's risk to the fetus. It's a balance of risk. So, it's rare for me to counsel a patient that there's not a benefit, but those studies really helped me. Like, I just was not comfortable sitting in that room saying, it's all great, everything's going to be great. It's just not who I was. I needed to have some data. I needed to understand how to really counsel these families so that they can understand that, well, the ventricles are between 10 and 15. That means that it halves the likelihood of needing a shunt, right? And it means that the incidence of improved function goes from 12% to 30%, of 2 levels. those are things, believe it or not, that these patients are very informed, and I think I try to explain that to them in a way that they understand.
Jay, thank you very much. That was terrific.
Well, I'm honored to be here. Thank you, Benny. And Raheel, just call me. We'll chat. And it's great to be with everybody. Thank you.
Thank you for the talk.